Hey, Super Mamas, it's Dr. Joy here, and you are watching Delivering Joy MDTV. Welcome to Super Mama Sunday. We've been doing this series on preterm birth, and I have my special guest that we've been talking to about the real deal about detecting preterm birth and some of the advances that we have for preventing preterm birth. So we're continuing our conversation today, and we are going to be talking about cervical length. Cervical length is one of the tools that we have. So Dr. Shania is back today, and I'll be introducing her shortly. You want to know about this, so make sure you keep watching. So today I have a very special guest. She is like black girl magic on 10,000. This is Dr. Shania Siebels, and let me tell you a little bit about her. I've got her bio here. Not only is she a medical doctor, but she's also an attorney, y'all. So this is amazing. She's board certified by the American Osteopathic Board of Obstetricians and Gynecologists. All right, Super Mamas, let me run back this intro for Dr. Shania so I can drop her receipts, because my girl is highly qualified to talk to you guys about this topic today. You mentioned something about cervical length. Will you talk a little bit more about that?
Yeah, the cervix is a really important component of pregnancy and maintenance of pregnancy. The cervix is the mouth of the uterus. It's what connects where the baby is to the vaginal area. And when a woman labors, the cervix is the tissue that needs to open up and allow the baby to pass vaginally. And many times when a woman is delivering very early, the cervix is part of the issue. The cervix either starts to dilate early on. Sometimes women don't even notice that it's doing that because they're not having pain or contractions. The cervix on its own just starts to open up and dilate, and that can of course be very dangerous for the pregnancy and increase risk of pregnancy loss and very early deliveries. And so what we do for women who have either delivered early on, and in our office we do universal cervical screening for all of our patients too. And I know many people are instituting this now, because what we know is that yes, we can identify risk factors for preterm birth, but most preterm births are still occurring in women without risk factors. And so even in the first pregnancy, we don't know how the body is going to respond. And so we do the universal cervical screening here at the time of the anatomy scan, which for most women is between 18 and 20 weeks. But for women that have delivered early before, we don't wait until 18 and 20 weeks to start looking at the cervix. We want to start looking at it much earlier, because we want to know if it's starting to either shorten, decrease its length, which you can only diagnose really from a transvaginal ultrasound, and or we want to know if the inside part of the cervix, the part that you cannot feel when you do a pelvic examination on a woman or see when you do a pelvic examination on a woman, is it opening up early? Those kinds of changes can also be risk factors for preterm birth. And if we start to see those changes, that's when we start to talk about either putting a woman on vaginal progesterone if she's not already on a form of progesterone, or we start talking to women about the stitch or putting what's called a cerclage into the cervix to keep it closed and reduce risk of preterm birth. So it's a very important component of managing someone's risk of preterm birth.
I just feel like so good right now because, my sonographer is fantastic, and she started doing universal cervical length maybe a year or so ago, and I was like, oh, okay, at every anatomy scan, and she's like, oh, I'm gonna check the cervical length, and I'm like, so I feel like we're like, cutting edge, because we're doing what Dr. Shania does at her office.
Well, I look at it like this, and we do it, and yes, we look at a lot of normal cervical lengths in the mid-trimester of pregnancy, but we have found very abnormal cervical evaluations in folks on their first pregnancy. I found very abnormal cervical evaluations on women fourth pregnancy that had 3 term deliveries in the past, but here we are at 20 weeks and the cervix is fully dilated. Not fully dilated, but dilated throughout.
Right.
And no one, and they have no symptoms. So there was nothing that would have brought the woman to the obstetrician to say, hey, something is going on, something's not right. Sometimes there's no symptoms. And so for us, the way I look at it is if we can prevent one preterm birth, to me, it's worth all the cervical lengths that we do.
Mm-hmm.
Or achieving viability, or getting a baby further along, that's reducing those adverse neonatal outcomes. I mean, it's just super important. So yes, we've instituted that, and I know many of our perinatal colleagues have instituted that too, and lots of us feel strongly about cervical unscreening at least once for all women in every pregnancy.
Yeah, and I think I've called you before on a patient that was her first pregnancy, and we found that her cervix was like very, very short. And I'm
Mm-hmm.
like, I think I want to put a cerclage, and I was like, but it was kind of new territory, because that's not something that we were doing in general obstetrics before. And I was like, this cervix is really short and she has no symptoms, but I'm thinking that the cervix is funneled, it's short, I think she needs a cerclage. So I put a cerclage in, and now the person is third trimester, she's doing great. So I shudder to think what might have happened if we had not been just done a transvaginal cervical length on this patient at 20 weeks.
Mm-hmm. Yeah.
So I totally agree with that philosophy, because when women would just have painless cervical dilation, they might have their water would break, and then they'd have a baby, and the baby would not be able to live outside the mom yet, or would be pre-viable, and that's heartbreaking. I mean, if you could keep someone from having to go through that,
Mm-hmm.
it is certainly worth looking at 1,000 normal cervical lengths.
That's right. That's right. Yeah,
Um,
and unfortunately, I see. I'll go over to the hospital and do consults when we're already at that place. With
right.
17-week mom and 18-week mom, membranes prolapsing, and no history, no real significant risk factors. There was nothing different going into this pregnancy that an obstetrician would have done. And so we have the conversation, and it is very important, I think, to talk about being an advocate for yourself. These things can be very muddy, as we talked about, looking at the history and trying to decide what is correct or the best management strategy for the current pregnancy. There is not always one right answer.
Right.
The true definition of cervical insufficiency or incompetence, and that's when a woman's body or the cervix just dilates. A woman has no symptoms, no contractions, no pain. The cervix just dilates. The true definition is really 2 prior mid-trimester pregnancy losses of painless cervical dilation.
That's
That's a tough. That's a tough one, right? Because
I
when
mean,
you
I
see
think
a
it's
woman
nuts. Like,
who's had that happen to her once, to sit there and say, "Oh, well, we wouldn't do anything different in this pregnancy. We'll just see how you do, and if this happens again,
no,
then we'll do
absolutely
something."
not.
That it's hard to justify that. We'll at least follow the cervical length. I mean, come on. We'll at least look at the cervical length, and sometimes, depending on what the history appears to me, I may say, what, let's just at 14 weeks put in a stitch. And so, so you may find some variances if you're going to different obstetricians into how hard and fast they'll use that definition, etc. But one mid-trimester pregnancy loss honestly is too much, and
Exactly.
we cannot make risks in pregnancy zero, and so we certainly can't prevent all untoward outcomes. We just can't. We wish we can, but we can't. But usually, if I have that story once and we've got that history once, I tend to be like Dr. Baker here on the more aggressive side, that we have
Yeah.
to do some things in the subsequent pregnancy, the next one, right? To try to, maybe the cerclage right away isn't the right answer, but we're going to at least follow the cervical length. You're going to get some progesterone. And
Right.
so, but if there's any abnormalities that are coming up, then we're going to be very quick to put in a cerclage if we haven't already done so. So, so
Yeah.
I have seen that before, where there are some differences of opinions about, the bona fide definition of cervical insufficiency and when we should start putting in stitches, etc. And so those are things,
I,
and that's
you
valid.
know, I am not one to, I don't know that I have the authority to challenge years of historical definitions or whatever, but I do know that we cannot afford to get stuck in dogma, and we have to do what's best for the patient. I remember when I was in residency at Morehouse School of Medicine at Grady. My department chair, Dr. Matthews, always said, always do the right thing for the patient first and then worry about the other stuff later.
Right.
And so I don't think that, first of all, one loss is devastating to a
Mhm.
family unit. So for me to say, oh, well, let's see if you have two, and then the next time we'll treat you. I think that's the most absurd thing. I would never do that. Like I would not be able to live, sleep at night doing something like that. So if I have someone with one loss, I think we need to be aggressive. And if we have the ability to screen to prevent even that one loss, then I think we should do that, because
Mhm. Mhm.
that's kind of our duty to care for women. So I totally agree with you. I think being more vigilant and aggressive when we can be is the way to go with our patients. And of course, shared decision making is important, and giving families the tools they need to advocate for themselves as well. Like, because OB is such a widely varied specialty. And there's so many ways to skin a cat, as they say. Like,
Mhm.
as long as it's reasonable, people may have lots of different plans and lots of different ideas about what they do. And it doesn't necessarily make it wrong, but, there may be uh, second opinions are always a good idea. I don't ever get offended when someone seeks a second opinion. As a matter of fact, I advise it, because, like I said, medicine is a team sport. And I always love when I go to conferences at the Society for Maternal Fetal Medicine. I go to the OB Critical Care Conference every year. And this one guy always says, if you ask 3 different MFMs, you'll get 6 different opinions.
That's right. That's right. That's very true. It's
So,
very true. We live in the gray zone where that's why our opinions are sought out, because it's a gray area oftentimes, and there's a lot of different ways that you can manage that. So, but I think it's important for patients to understand that just because you may hear different responses doesn't mean that one is wrong and one is right. Just understand that there are different ways to manage pregnancy history, prior preterm birth, current, different issues from the cervical standpoint in the current pregnancy. So, but you have to have that conversation with the patient. And it's all about shared decision making. And usually what I try to do is I try to give the patient all the information as best we know.
right.
As best we know based on what your history is, as best we know based on what I'm seeing on ultrasound, the cervical length evaluation, or the pelvic examination, and then present all the information about these different options, progesterone, the 2 different kinds, and then of course cerclage. And we have a conversation about what that looks like. Sometimes I give a strong recommendation about what I feel from a medical standpoint it will reduce the risk the most. Sometimes I'm more lukewarm about it because the information may be a little more not so high risk. But certainly there are some situations where it's very obvious to me what the best risk reduction method is. You got a patient with a prior history of preterm birth and a cervical length of 5 millimeters, at 18 weeks. That's a stitch, right? So,
Right.
some things are very, very much easier, and the recommendations will then be more clear cut for me. But other things may be much more gray, and the recommendations may not be as strong. And so we have to have that interaction with the patient, and what do they feel, and what do they think about these different options and these different methods for risk reduction. And different people choose different things. Some people say, you know what, let's continue to watch the cervix. And then if it continues to shorten, because maybe it's only 19 millimeters right now, maybe it's not as easy of a call for a stitch, and maybe they want to avoid a surgery. So, or other people may say, no, I've done this twice before. This is, I want to do anything to reduce, and
Right.
so they want to, pursue. So it's there's a lot of
I
people.
like those people better because for me, I always feel like if I have to do a cerclage, I want to do it before I get to the 5 millimeters.
That's right. That's right. It's true. That's part of the conversation. Listen, we don't want to. I don't know what this is going to look like in a week. You don't know the rate of cervical change that may happen. So I say that to patients. Yeah, we don't want to wait until the cervix is open. It makes it higher risk, more difficult to place. The risk of the cerclage failing is higher, etc. All of these things. So that's.
Yeah, I'm like, please don't give me the 5 millimeter cervix. Can we please go when it's 19 millimeters? So, because it's such a nerve wracking procedure to do. Every time you're putting that stitch to get that purse string suture, you're like, oh my gosh, am I gonna break the bag of water? Am I gonna do something that's gonna decrease our chances of success? So I think about that. Two more questions, because I really appreciate your time, and I know you're so super busy, but will you just briefly speak on transabdominal cerclage? I sometimes get questions from patients about that who have had a cerclage in the past that failed a vaginal cerclage. When do you move towards that, or is it something that you recommend in practice?
Yeah, I rarely come across a patient that has what I would call an indication for a transabdominal cerclage, but there certainly is a role for transabdominal cerclage in preterm birth risk reduction. Typically, it's the patient that has had prior preterm birth, has undergone a prophylactic cerclage placement, prophylactically, meaning that it was placed early enough in the pregnancy that labor wasn't occurring, the cervix wasn't dilating or doing any changes. So we placed it where the cervix was still nice and long and thick, and we had good tissue to work with. But yet and still, with that pregnancy, we went on to either have, a pregnancy loss, typically a pregnancy loss, but even a periviable birth or a very early birth where the cerclage just didn't do what we would expect it to do. And the goal, of course, is to get someone to term. Now, the difference between a transvaginal cerclage and a transabdominal cerclage is how you're putting the stitch into the cervix. I usually tell them in a transvaginal cerclage experience is as if you're having a pap smear. When you go to the OB, you're in the stirrups, you access the cervix vaginally. So you put a speculum in. It's like you're having a pap smear. From our experience, we access the cervix, we put the stitch into the cervical tissue from the vaginal way. When you do it from the vaginal way, there's only but so high up you can get on the cervical tissue, because the cervical body, the full cervical body, much of it is into the vagina, but some of it is not within the vaginal canal, or not easily accessible from the vaginal standpoint. So you can get a stitch higher up on the cervical tissue if you do it transabdominally, okay? Because some of the cervical body is into the pelvic cavity there. And so that's the difference. And we think that if a woman has failed the transcervical or transvaginal cerclage, then the next step is to try to get a stitch as high up as can be placed onto the cervix, and that would be via the transabdominal route. If a woman is in that particular situation, you want to find someone who does transabdominal cerclages regularly. We don't do them regularly here. There are certainly some perinatologists in various areas, and most of us have a person that will do a transabdominal cerclage, our go-to person, if you will, that we could send a patient to. Sometimes that may require travel out of the state that a person lives in. So there's a lot of significance that comes with that. Thankfully, thus far, I haven't had anyone here recently that has failed a cervical cerclage in a manner requiring a referral for transabdominal, but certainly that is.
Don't worry, I got somebody for you.
Oh.
Send her to you.
Send them on over. Yeah, we'll get it taken care of.
So yeah, that's why I was asking the question, because we were having the conversation, and I said, well, I'm gonna have to send you, to see Dr. Shania. So.
Yeah.
And then the last question is, I want to speak, because it's me, so I got to talk about it, about the disparities in preterm birth, and on how we think we can move the needle on decreasing the health disparity that exists with preterm birth. We know that Black women are twice as likely to have preterm births, and that we're twice as likely to have babies that are not going to survive that preterm birth. So,
Mm-hmm.
so what do you think about that, and how do you think that we can change that statistic?
Yeah, that's a huge and loaded question, as I know you know, because you do a lot of good work in this realm of obstetrics and these disparities that we have. It's so multifactorial, and so you really first we have to understand the complex nature of the problem. And I
Right.
think we have to be honest about the complex nature of the problem and all the different avenues that the problems are coming from, because there's a lot of different avenues. Some of those are medical conditions, right? We know that African Americans are higher prevalence of chronic medical problems, high blood pressure, diabetes, and obesity, and especially we're in the South, we're in Georgia. And so, we've got more of that than maybe some of our northern counterparts, but those things impact pregnancy risk, right? And so, but then that's just medical history. That's not necessarily things that we can control once we're encountering patients during the pregnancy, in terms of the history. Now we can control the management of those things during pregnancy and wanting to make sure that those medical conditions are optimized throughout pregnancy. But the other things that we need to be honest about and try to combat on a regular basis are things that are part of the system. I call them system problems,
Right.
We've got access problems, right? So the access to good physicians, good providers, obstetricians to take care of women. We know here in Georgia, we've got a lot of rural pockets that don't have good access.
Right.
You know, how do we get women to the providers and physicians that they need to get the best care that they should have, right?
Mm-hmm.
All women should have optimal care for pregnancy. But we
Yes.
know that does not happen for all women. And so that's a problem. That's a system problem. That's something that we have to figure out. Insurance companies have to get on board with not just looking at dollars and cents, but looking at what makes sense. And what makes
Ah,
sense is to spend money on preventative strategies. Why can't
absolutely.
insurance companies, and some, we have Medicaid, so Medicaid will provide travel for pregnancy visits, pregnancy associated visits. So things like that, can help increase access. But, we just talked earlier about, the insurance denial for something like IM progesterone in a patient who has a legit indication, and you have a physician who is saying my patient needs this to reduce her risk of preterm birth, but yet you may have a denial. And then
Right.
what comes with that? A preterm birth with a baby in the NICU. The cost of that
Super
is so
expensive.
much greater than
Right.
that it would have been to just pay for the progesterone in the first place. So we have to make things make sense. And so that's a system problem, certainly. Access to care, access to the things that we just talked about in terms of reducing preterm birth risk. Those things, I don't have easy answers to them. I don't have answers to them. We try to fight as best as we can as physicians and providers to get our patients what it is that they need. But of course, we are working within the system as well too. So the system certainly is a problem from that standpoint. And then we know that the disparities in medicine, there is a strong component that comes from biases from the system standpoint. Now, the system is hospitals and institutions. The system is physicians and providers and other healthcare staff that care for our pregnant women during the pregnancy process and thereafter. And so there's a lot there that needs to be tackled and honestly addressed. And that's a heavy task.
Yeah.
It's a heavy task. And I think that each of us as individuals have a duty to make sure that we are addressing our own biases, right, in taking care of our patients and the things that we see around us in our immediate environment, and helping to educate other folks and our patients, and trying to give our patients the tools to be advocates for themselves.
Right.
And then, of course, there are some of us who are superheroes like Dr. Baker, who goes above and beyond to try to gather data and information about what these biases are, how they are impacting our patients, and trying to educate those people within the system to be able to identify and have an honest conversation with themselves to improve their level of care for patients. But it's so multifactorial. There's so much there, and that there's not one easy answer. But I think that the conversations are being had. They're being had more often, on a more regular basis, on a more national basis. I know with both ACOG and SMFM, we're having these conversations, and those are nothing but good things. It takes time. It's going to take time for this to really evolve, and for us to see those things. But I think the more physicians and providers that we can get on board in terms of this conversation and addressing these needs and educating folks around us, the better off we will be. But that's not a quick and or easy fix.
I think you're right, but it gives me so much hope when I see that ACOG and SMFM are having these conversations, when I see other organizations having these conversations. I'm so excited to support Morehouse School of Medicine Center for Maternal Health Equity. And there are lots of research projects that are going on, and I'm going to be bringing you guys content on that and how my super mamas can get involved, because we can't do anything for you without you. We need your voices. We need to hear your experiences. And I am so glad that Dr. Shania was able to join us today. She's a regular contributor to Delivering Joy MDTV, and I'm just so thankful for her expertise and all of her knowledge that she shares with us. So definitely place your questions and comments in the comment section below, and I will catch you guys on the next Super Mama Sunday. So make sure you're subscribed, girl. We'll see you next time. Peace.